You'll hear that now, just so you all know it is being recorded. Welcome to this live webinar today. We are so excited to have you all here. My name is Jahan Corbin. This is my friend and co-worker, Lynn Haddad, and we are both breast cancer survivors, and we are a part of an organization called Breast Cancer Recovery and Action. BRA is our acronym, so you can insert your supportive puns there. We love the jokes. Breast Cancer Recovery in Action was founded in Middle Tennessee. It's a 501(c)(3) nonprofit about 4 years ago in 2021. And I'm just going to give you kind of a high level, quick overview of some of the resources we provide. So if you're not familiar with what BRA does, then you will be. And if you know of anybody that could benefit from our services, you're welcome to share this. At no cost to our participants, we are able to provide, I kind of say the 3 E's to keep it simple. The first thing is exercise. That's a main component of our program. If you're in treatment or out of treatment, you probably know that surgery on your upper body, radiation on your chest wall, having lymph nodes removed, all those things, recovering from a major surgery like a mastectomy, all of those things can affect your strength and flexibility and range of motion. And so we have people, whether you've been a lifelong exerciser or you've never exercised a day in your life, we know that it's good for us and it helps our mind, body, and spirit to move. And so, what that looks like in our group is a group setting twice a week with a personal trainer who's pink ribbon certified that knows exactly how to make modifications for people like us that have gone through those things and may be rebuilding that strength and flexibility. So, exercise is the first component of our program. The second thing is education, which Banter that you're participating in today kind of falls under that umbrella. We try to provide just education about all kinds of things that would be interesting and relevant to the breast cancer community from our esteemed physicians that we're going to talk to today. We've had conversations with plastic surgeons. We've also spoken to stylists who have talked to us about how to style your bald head or how to draw in your eyebrows when you're going through chemo. So it's not always high level sciencey stuff, but hopefully just something that would be a takeaway for somebody who's navigating breast cancer. And we also have lymphedema education, which is important also that falls under that education category. And then the third E is emotional wellness. And that is kind of I like to say it's a book club meets a support group. We work through a curriculum that is specifically tailored for breast cancer. It's 9 weeks long. You meet in a group setting of 6 to 8 people, and it's facilitated by 2 survivors. And we really, through that curriculum, work through some of the emotions, the grief, the loss, some of those things that come along with a cancer diagnosis. How do we process that? For a lot of us, I will say, I'm not speaking for everybody, but myself, this was my story. And for a lot of women I speak to, we kind of power through sometimes and you get through treatment and you're like, okay, I'm done. And then all of a sudden you think, why do I feel like I've been run over by a truck emotionally? There's a lot more that comes with a cancer diagnosis than just the physical stuff. So that emotional support is really critical, and it's amazing to have a safe place to process that with other people who have a shared experience. So that's who BRA is. We are here for you and would love to help anyone that could benefit from those resources. But today we are having a specific conversation about the effects of chemo and our cardiac health. So I'm going to turn it over to Lynn to introduce us to our speakers.
Yes, thank you very much. I am so lucky to get to introduce Dr. Serene and Dr. Nunnery. So first, I'm going to introduce Dr. Serene. She is the medical director of the Women's Heart Program at Ascension, and she is an interventional cardiologist. She is a passionate advocate for gender equality in cardiovascular health care, a strong advocate for making women's healthcare accessible, consistent, affordable for both patients and the healthcare system. And as those of you who attend Broad Banters, you know that whenever we do an introduction, we like to include a fun fact. So I pulled my fun fact from a YouTube video that I saw, and I wanted to include that Dr. Serene loves to dance. That's why I tried to connect her with Brittany a few minutes ago. So maybe we can convince Dr. Serene to come see Brittany's dance class. But I also know that she has a husband who's a guitar player, so I think they're in the right city. Dr. Serene, we always like to find out what brought our guest into their particular career. So would you mind sharing with us a little bit about what brought you to the medical world?
Well, thank you. That was a great introduction. Trust me, I've never had so much dive into it. And frankly, I'll be honest with you, I think dancing and music defines me more than medical fields. I'm so glad you included it.
Really?
And if I was not a physician, I probably would have gone into dancing as a professional career. That's how
Oh,
much I love
really?
it.
Wow.
Yeah, and so medicine was actually a natural choice because my dad's a pediatrician, and I saw medicine very early in my life, being practiced at home. And also my mom's a community worker, so we used to see a lot of disparate health, gender inequality, and so it was a very early sensitization for me, and it was very organic. But cardiovascular, heart health particularly, was when one of my close friends, I was actually in my teens at the time, and she had a sudden death during an athletic event at our school, which was pretty traumatic for everybody. And long story short, at that point, I started to dig more into heart health, started to listen more to the patients that dad used to get, mainly concentrate on their heart. And that's how heart happened. And now I'm a plumber of the heart and I open up clogged arteries for a living.
I've never heard described quite like that, but I'll make a note of that.
I love that. What a
All
great
right.
introduction. Well, Dr. Shreen, we'll kick it off with you. We had seen some comments or heard your comments about heart disease management not being a necessity, but should be a necessity, not a luxury. And we certainly could not agree with that statement more. Can you kind of expound on that a little bit? What have been some traditional obstacles, um, in terms of making that a necessity and not a luxury? Is it insurance or perception about heart disease being a man's disease or other things?
That's a great question, and I think a little bit of everything is genuinely the right answer. The problem with it starts with perception, and when there is a lack of perception and advocacy, it translates into reality in clinical practice. We only can fix issues that we understand and we have tested. And in our clinical trials, and the way we treat our patients, the way we test them is based upon our guidelines. And those guidelines come from clinical trials. If you pick up any clinical trial, 85, 90%, in fact, even 95% of participants are men. So everything that we apply, any medicine we give for heart failure, any device we put in, a heart pump that we put in, a stent we put in, has only been tested in men,
Hmm.
has almost never been tested in women. And the time when we started to realize it is when I do heart attack patients for a living. We open clogged arteries, and women react very differently. When we put a heart pump in, the chances of a woman having card having for the lack of a better word, actually dying from a big heart attack is much higher than a man. If you look at diabetes, with the current treatment that we have, if a woman develops diabetes after 45 years of age, her chances of stroke and heart attack are 6 to 7 times higher, while that of men is only 2 to 3 times higher. Hypertension, atrial fibrillation, irregular heart rhythm. If you're a female, just being a female and you have AFib puts you at higher risk of stroke. Significantly so that just being a female with exact same risk factors as a man, you should be on blood thinner. So little things like that, which started with the basic issue of inadequate representation in clinical trials, has transpired into lack of representation in guidelines, lack of treatment that we understand and we deliver, and hence insurance companies that also rely on the guidelines fail to reimburse for issues that affect women disproportionately. So it's all a vicious circle.
Is it?
Mm-hmm.
Well, and I think that one of the things that Dr. Nunnery is going to talk about is the chemotherapy that many of the people on this call have gone through. So with that, I am going to introduce Dr. Nunnery. Dr. Sarah Nunnery is the director of breast cancer research at Tennessee Oncology. She has studied at the University of Tennessee, University of California, San Francisco, and Vanderbilt. Uh, Dr. Nunnery was awarded an ASCO Young Investigator Award for her research in the triple negative breast cancer biomarkers.
One who.
Dr. Nunnery's goal is to bring the latest clinical trials with cutting-edge therapies to patients with breast cancer across the communities of Middle and East Tennessee. So I also have a fun fact about her, and I've never met her before, but I happen to know she's really funny. I was diagnosed with triple negative breast cancer 8 years ago, which is not funny at all. But when I was researching her online, I saw that she co-authored a journal article called Triple Negative Breast Cancer, Breast Tumors with an Identity Crisis. And I think anybody
That's
who
funny.
authored a journal article called that, which is actually exactly what my oncologist told me. She said someday triple negative is not going to be called triple negative because all they're calling it that is what it's not, which is it's negative for the traditional, HR or ER positive. It's basically being identified by what it's not. So it's having an identity crisis. So I think you're very funny. And I always appreciate a funny doctor. There have been a lot of days when I was in a cancer center that I needed somebody to joke around with me.
A humorous assistant is a very, very valuable
First waiting goal.
That's right. That's right.
That's my funny fact about you. I promised it would be a good one.
I love it. Yes, thank you. Great one.
But anyhow, so I think a lot of the information you're getting ready to share actually follows up perfectly with what Dr. Serene was just saying in terms of the drugs that you sometimes, right, prescribe in chemotherapy. Is that not true?
Absolutely, yes. And the field is rapidly evolving with so many new drugs too, and I'll get to touch on a couple of those. And with all of these new drugs coming into the marketplace and coming through trials, we are learning more and more about cardiac effects. But really, our hope is that with some of these new drugs, we will start to move away from drugs that have as much potential cardiac risk, and really start to maximize benefit for patients by also minimizing some of that toxicity. And that's a big focus in triple negative breast cancer right now too, really trying to see how we can de-escalate therapy and minimize some of that toxicity with a lot of these new drugs. But so glad that this is an area we are learning more about and really starting to follow some of these long-term effects for our patients. Let's see. Do you want me to go ahead? Can I take it away now with
You go.
these slides? Let's see if this is all right.
Dr. Nunnery has prepared some slides that we're going to start off our conversation with. And I believe Dr. Serene can,
Absolutely. Is everyone able to see my
that's
screen?
the word I was looking for.
Yeah,
I
okay,
still have chemo
Yes.
brain 8 years later.
No, you're fine. And yeah, this really, we want it to be informal. So please, anyone speak out at any time. Lynn and Jahan, y'all know y'all are watching the chat. So just shout it out if someone says anything in there. But I just wanted to give kind of a quick overview of some of the most common drugs that we use in breast cancer that can have some cardiac risk. And some of these might be some newer drugs or things that you haven't seen before. But hopefully it will be a good refresher and set the stage for a lot of the things that Dr. Serene will talk more about with her expertise. So I think the biggest thing that comes to mind is, of course, chemotherapy, particularly anthracycline chemotherapy. And the main drug that's an anthracycline that we use for breast cancer is doxorubicin, so affectionately called the Red Devil. I had a patient recently who said she's trying to change that, and we're going to call it Jesus's blood from now on to flip it from the Red Devil, which I thought was hilarious. But doxorubicin is the main one we use for breast cancer. They use epirubicin in Europe and some other countries, and then there are other anthracycline chemotherapy drugs like daunorubicin, mitoxantrone that are used in other cancer types, not so much breast cancer. But doxorubicin is a drug that's meant to kill cancer cells by damaging the DNA in the cells. And by doing so, that process generates free radicals, which cause stress on the cells, and that kills the bad cancer cells, but it could also affect the myocytes, which are the cells of the heart. And so thankfully it's rare these days, but this drug can cause heart failure and cardiomyopathy. And when that happens, that is irreversible. Usually, if something like this happens, it's within 30 days of a dose of the drug, but it is possible that it could occur up to 7 to 10 years later. The risk of heart failure with doxorubicin, it is really dose dependent. And as we learned that with time, there are now maximum lifetime dose limits that patients can receive with this drug. The maximum limit is 550 milligrams per meter squared. The risk of cardiomyopathy at that maximum dose is around 4% or so. Um, sorry, with staying under that dose, we should be under a 4% risk. If you go above that dose, like 600 milligrams, 700 milligrams, which we at once did give that to patients, the risk starts to go up to 7%, not negligible risk. We like to lower that dose in patients who have a history of prior mediastinal radiation. Usually that's done for like Hodgkin lymphoma or some other lymphomas if patients had a lymphoma when they were young. When someone gets AC chemotherapy, which is the typical regimen we give for breast cancer that involves doxorubicin, the cumulative dose that's given with that regimen is 240 milligrams per meter squared. So less than half of that maximum dose limit is reached with that regimen. And with doses at that level, the risk of heart damage from this drug is thankfully less than 1%. So hopefully that reassures, a little reassuring for people to hear that we are staying well away from that maximum dose where we start to get worried. But regardless, this is something we always want to be conscious of, and we should always be getting a baseline echocardiogram or ultrasound of the heart before anyone starts treatment. So we have a baseline, we make sure somebody doesn't have some undiagnosed, heart disease or issue before they get treatment with this drug.
No, that is reassuring.
Mhm.
I didn't know it was that low.
Yeah. And then I want to move into some other drugs that may not so much be on your radar, but some of the drugs we use for hormone-driven breast cancer or those ER, PR positive breast cancers. Of course, the backbone of treatment for those is endocrine therapy. So aromatase inhibitors are the primary hormone blocker pill that we use to treat hormone-positive breast cancer, particularly in our postmenopausal patients. Premenopausal patients might need these as well in combination with medication to block the ovaries. And these drugs can be associated with increased risk of ischemic heart disease, mainly because these drugs can affect lipid metabolism. They can unfavorably alter lipid profiles by raising LDL, lowering HDL, which is the good cholesterol, and increased risk of developing atherosclerosis or clogged arteries that we would need Dr. Serene for. They could also potentially increase blood pressure. I don't see that too often, but I definitely have some patients who notice their blood pressure runs higher when we start one of these medications. The aromatase inhibitors are associated with a higher incidence of cardiovascular disease compared to tamoxifen, which is another one of our hormone blocker pills, especially if it's a patient that already has some pre-existing risk factors for heart disease. So in terms of trying to nail down, what exactly is the increased risk with these drugs? It's actually really hard to know for sure. The numbers are widely variable based on studies. There was a recent big population-based studies published out of Sweden looking at a big population of patients on AIs, and they found a 50% increased risk of heart disease for patients on these drugs, which is quite high. But the caveat with that study is they did not have any data on other risk factors for heart disease for the patients in that study. So they didn't know the BMI of the patients. They didn't know the smoking status of the patients. They didn't know family history. And the authors of that study were very clear in their discussion when they presented the data that there's big limitations there. So I think I won't stay too long on my soapbox about this, but I always want to caution people when going to Dr. Google or reading any kind of clickbait on social media about increased risk, because a lot of times people are not actually reading the full study and kind of getting into the nitty-gritty. So always talk to your doctor, especially talk to your cardiologist, because there's so many individual risk factors at play for each person that could drastically affect the risk. You know, if you're someone that already has, you know, big family history of heart disease, or you already have a history of elevated cholesterol, you know, your risk is going to be much higher. And so you really want to make sure we're optimizing all of those risks with the help of our cardiologists like Dr. Serene. And just a word on tamoxifen. Tamoxifen has been thought to have a little bit lower cardiovascular risk than the aromatase inhibitors. There's also some data to show that it can reduce total cholesterol and LDL. But I just want to caution that that doesn't mean it's necessarily good, and it should not be used as a primary cholesterol medication by any means, because it can also reduce the HDL cholesterol, which is one of our quote unquote good cholesterols. It can raise triglycerides. So we definitely still want to be mindful of our cholesterol and maximizing all of our other risk factors to protect ourselves against heart disease. There's also a little bit more of a thromboembolic risk or risk of blood clots with tamoxifen. And that's due to an effect on proteins in the liver, your clotting factors in the blood. But thankfully, that risk is also very low. So not a situation where we have to worry that our patients need blood thinners or aspirin every day. There's been a lot of studies looking at that, and thankfully, the risk has not been deemed high enough to warrant that. There's been no change in outcomes for having patients take any type of aspirin every day. So I always tell patients, you know, as long as you're staying active, you know, stay moving. If you're going to be in a situation where you're going to have added risk of blood clots, like you're going to be having a surgery where you're going to be asleep or immobilized, you're going to be, you know, flying to Australia or something like that. Those might be situations where I would be more worried about the clot and might want to hold tamoxifen. A lot of our surgeons will like patients to hold tamoxifen before a surgery, but all in all, risk of clots are low. That the average person doesn't need to do anything particular for that.
May we ask a question that's come in from the chat, Dr. Nunnery?
Absolutely.
What about the risks when we stop taking these meds? Do they go away?
So another great question that I think we are still actively studying and trying to understand, especially from some of these big longitudinal studies like the Women's Heart Study and things like that. They should go back down as we remove the drug and estrogen levels are restored to the more natural level. But it's definitely something that I definitely still want patients to continue to follow with their cardiologists and make sure we're keeping a close eye on risk factors. Other drugs that we use that can affect the heart are drugs for our HER2 positive breast cancer and our HER2 targeting drugs. The big ones are trastuzumab and pertuzumab, which are also the brand names for those are Herceptin and Perjeta. These drugs are monoclonal antibodies to the HER2 receptor. And so the HER2 receptor is vital for pathways in the cells related to cell growth and proliferation, and they get mutated in some breast cancers and just become hyperactive and make these cancer cells grow like crazy. And so these HER2 targeting antibodies, you can see kind of a illustration here, they go and they block those receptors and turn them off to shut down those pathways. A lot of our normal tissue in the body also has HER2. It is a normal protein, a normal pathway. It's just that it gets mutated and kicked into overdrive in these breast cancer cells. And so with these HER2 targeting drugs, they can bind to HER2 receptors on the myocytes, the heart cells. And so they can also have cardiac effects and potentially weaken our cardiomyocytes. Unlike anthracyclines, effect from these drugs are not dose dependent. It can really occur anytime during therapy. And thankfully, it is usually reversible with holding the drug. So any patients who are getting HER2 targeted drugs, we need to get a baseline echocardiogram before starting treatment and then monitor that echocardiogram at least every 12 weeks, every 3 months while continuing a HER2 targeted treatment. And if we see any changes in the heart function on an echocardiogram, that's when we rely heavily on our cardio oncologists to monitor the heart function. Sometimes they will go ahead and start patients on some cardioprotective drugs like a lisinopril, an ACE inhibitor, or a beta blocker, and follow the echocardiograms a little more closely while we're getting patients through treatment with these drugs. A couple of new drugs on the block. More so here is this drug in HER2, Kadcyla or trastuzumab emtansine we've been using for a while for HER2-targeted breast cancer. But these are called antibody drug conjugates. These type of drugs are really all the rage right now in cancer care. There is a million new antibody drug conjugates, or what we call ADCs for short, in development, coming down the pipeline. This technology, it's really amazing. What these drugs are they are monoclonal antibodies, which is what that Y-shaped protein is. But what we've been able to do is engineer these antibodies and attach little chemotherapy particles to the antibody, which almost look like little ornaments tacked onto the antibodies here. And so when we infuse these drugs, which are still IV treatments, these antibodies can go and bind directly to receptors on the cancer cells. And you can see the cancer cell takes up the antibody, and the chemotherapy gets delivered directly into the cancer cell for more effective killing of the cancer cells, essentially. And then we minimize the risk and damage to other normal cells. The other thing that's cool about these drugs is they have what's called a bystander effect. And so what happens is when these chemotherapy particles are released into this cancer cell and it kills this cancer cell, those chemotherapy particles can continue to permeate and move into neighboring cells and kill them as well. So these drugs are incredibly effective. We've really seen them transform outcomes for patients with metastatic breast cancer. We are now seeing these drugs move into early stage breast cancer as well. So you'll be seeing a lot more of these drugs, especially in HER2. But because these drugs still have binding to the HER2 receptor, we still need to be monitoring patients with that echocardiogram every 12 weeks while they're on these drugs as well. And then the last drug that I want to touch on is immunotherapy, particularly pembrolizumab. The brand name is Keytruda. It's been around for a long time. We've been using it for melanoma and lung cancer and renal cell and lots of other cancers, but we've only recently been using it for breast cancer in the last few years. It is only approved to be used in triple-negative breast cancer. These drugs are also monoclonal antibodies, but they bind to PD-1 receptors, or others will bind to PD-L1 receptors on T cells. T cells are white blood cells that are part of your immune system, and it really helps to activate the immune system and allow the immune cells to suddenly see the cancer and start attacking the cancer. And so rarely, as a result of these drugs stimulating our T cells can get a little overexcited sometimes and attack normal tissue in the body. And rarely that could be the heart. We can see these T cells infiltrate the heart, these cardiomyocytes, and cause damage there. This can cause myocarditis or pericarditis, which is when it causes inflammation on the lining of the heart. This happens very rarely, thankfully. Usually we see it within the first 6 to 12 weeks of therapy. When it happens, it has a very high mortality rate. So this is a side effect that really scares us as oncologists, and we really watch closely for this. We treat these effects with steroids, high-dose steroids. The goal is to calm down the immune system as quickly as possible to minimize damage. But again, thankfully, this is very, very rare. Less than 1% chance of myocarditis. The overall incidence of cardiac effects from these drugs is about 1 to 2%. My colleagues over at Vanderbilt, Doug Johnson, they've really pioneered the research of myocarditis and do a ton of research over there on myocarditis from immunotherapy. And this is just another kind of quick note about workup and treatment of cardiotoxicity from immune checkpoint inhibitors. Again, we immediately involve our cardiology colleagues and our cardio oncologists. Patients will get admitted to the hospital. We will very closely monitor their heart with EKGs, TTEs, a lot of blood work. Sometimes they want to get a cardiac MRI or cardiac catheterization to, more closely evaluate the heart. And again, the treatment is high dose IV steroids and other immunosuppressive medications. But all in all, this is thankfully very, very rare. I don't want to scare people, but I want to emphasize that it is quite rare. But again, if anybody's ever getting treatment with immunotherapy, I always tell people if you start to notice any chest pain or shortness of breath, even if you think it is small and mild, please let your oncologist know. We want to know because we don't want to miss a toxicity like this, even if it's rare. If we act early, we can make a big difference.
Awesome.
And just, yes, some kind of key takeaways. Again, cardiac effects of treatment, they are really variable depending on the type of treatment. Monitoring is also variable. Some treatments require regular TTEs, some don't. Oftentimes, we need to get our cardio oncologists involved if we are concerned or feel like a patient's more high risk. But really, as you were saying with these, our endocrine therapies, heart health, it really does go beyond the treatment period. Maintaining healthy lifestyle to just optimize risk factors for heart disease is so important for our breast cancer patients. And it's a clear mission of BRA, which we're thankful for y'all's work on that. And if you have concerns, always meet with cardiologists so they can thoroughly evaluate your cardiac risk overall and make sure we are doing everything we need to do to optimize that risk and lower that risk as much as possible. And that's right where Dr. Serene comes into the picture to help us. Let me stop sharing.
One leftover question on AIs
Yes.
and I didn't want to interrupt you. The question was, does the risk of cardiac effects increase after more than 5 years on an AI?
In terms of clear data and like the changes in risk, I don't think we have any concrete numbers, but we certainly know that there are more risks the longer you are on a hormone blocker. And we see that not only with cardiac risk, but like on bone density and all of these other things as well. So definitely something if someone's doing, extended endocrine therapy up to 10 years, really making sure we are watching for those toxicities, making sure our heart health is healthy, our bones are healthy is so important.
Well, that's actually a perfect segue to Dr. Serene because I am one of those people that had, an EKG was recommended, just a cardiac baseline before I started my cancer was ER positive, so I did the Red Devil and Taxol and just sort of the typical protocol. Which, by the way, let me make a note about the Red Devil. What did she call it? Jesus is what did she call
She
it?
called it Jesus's blood. She's like, I'm flipping the script on
I am
this.
usually such a positive, optimistic person. I really am. But I have to tell you, my oncologist, who I adore, one time when I was in the middle of treatment, he said to me, I just don't like that y'all call it the Red Devil. We should call it something else. And I was like, I'm sorry, are you taking it? Because until you are, I'm going to call it whatever I'd like to. Thank you very much.
Put whatever spin you want on it.
I said, I'm all about seeing the glass half full, but come on. So anyway, we had a good laugh over that. He learned his lesson.
Some
He didn't bring that
things
up
cannot
again.
be dressed up.
We just call it whatever you want, but if you're the one taking it. Anyway, so Dr. Serene, I was one of those people that did the baseline EKG. I'm curious, and I mean, at the time, I didn't even have the wherewithal because I was like drinking from a fire hose with all the new information after my diagnosis. But I didn't have the forethought to even ask what kinds of things are you looking for? So, like, what are the cardiac measures that you would be looking for changes, from your baseline before chemo and then afterwards?
That's a great question. And something from a cardiologist perspective, one thing we cover is it is of course individualized, right? So everybody who gets these medications does not always develop cardiovascular complications. One of the things we're looking for is ejection fraction, which is how much is the heart muscle pumping forward. Echocardiogram typically helps, but Cardiac MRI is one, or MAGA scan is something that's more reliable because it's not dependent. I'll show a couple of images of what an echo looks like to us as cardiologists. And then you can sense that somebody's going to say it's 50%, somebody's going to say it's 45%. And we have tried to develop novel ways of knowing it at the cellular level by doing strain imaging, but that's also something that's just getting developed. So how do we measure it is really important, particularly in high-risk patients. Second, what's your underlying risk is really important. And third is our close collaboration with our oncology colleagues. Is there an alternative, or do we have to resume this medication? If we do it, do we put in cardioprotective medications on board and then monitor the patient closely? Also, particularly with doxorubicin, adriamycin, there is acute toxicity, we'll touch upon it a little bit, and then there is chronic toxicity, long-term toxicity. And the ones that develop toxicity quickly, early on, they are the ones that we stop, it tends to reverse. But once it's chronic, it's the one that stays. And then the dose that Dr. Nunnery was mentioning about also becomes really important. And if we follow our algorithms, we have algorithms published when the patients come to us, once they have been recognized to have CV, adverse outcome, or once we're at high risk. And if we follow that algorithm, in that case, it's 7 times decreased chances of having heart failure. So it's very effective. That collaboration is very, very effective. And Dr. Nunnery did such a great job with the presentation. I mean, she's going to make me look so bad.
Oh.
Try.
Believe it,
Probably.
we have no comment on that.
No, you look bad at all.
Highly doubt that.
Let me share. Is it okay if I share my
Yes,
presentation?
Please
no.
do.
Okay. Are you able to see my slides?
Yeah.
Let me go to slideshow right there.
Okay.
So I'm just going to go over a cardiologist perspective. I'll try to do it in the next probably 10 minutes or so we have time for Q&A. And my disclosure is that I have a daughter who's 7 years old, and we want to make sure as we are diagnosing more heart disease and more breast cancer, how do we make them live longer with less adverse effects and focus on quality of life? And that's where this collaboration comes in. We have 14.5 million people who are living with a history of cancer. We have 12,500 new cases that are diagnosed annually in children and adolescents, and this number is going on. And when we talk about heart disease risk, breast cancer chemotherapy is a really important part of it, particularly in women, but there is an array of medications and chemotherapeutic agents that are given for different cancers, and we have to closely monitor them as well. The risk factors that we are looking for typically are mitigated with a very collaborative approach, very close work relationship with our oncology team. So the cardiologist, oncologist, we work together, we monitor the patients together. There's a lot of to and fro. There's about, hey, what's the best for this particular patient? Hey, we usually don't do aspirin, but maybe with their risk profile, should be just do an aspirin in this particular patient or not. So it can be very individualized. I wouldn't panic if somebody with the same medical therapy is getting a different treatment regimen compared to you. The critical goal that we work towards is to see how can we improve the quality of life long term. And heart, if you think about it, it's like a room, the room we are sitting in. There's walls, 4 walls, there are 4 doors, there is plumbing, there is electricity. So when we say something's wrong with the heart, how can chemotherapy affect it? It could be either with the walls, it could be with one of the doors, it could be with the plumbing, it could be with electricity. And that's all we monitor when we are working with patients who are undergoing chemotherapy. Dr. Nunnery beautifully talked about doxorubicin, anthracycline agents already. So I'm only going to focus on some of the important aspects from a cardiac standpoint. What is it that we look at? We are looking at that room's wall. We are looking at that wall. Does it look the way it looked? Is it dilating? Is it functioning fine? And that's what we call cardiomyopathy. And when a patient who has weak heart muscle develops fluid in their lungs because they can't push it forward, that's when they have congestive heart failure. So it's not interchangeable. Weak heart muscle doesn't mean you have heart failure. It's cardiomyopathy. It's weak wall. When it's functionally not doing a good job, then that's when it's congestive heart failure. As I told you, there is acute short-term toxicity, and there is a long-term toxicity, especially with doxorubicin, which is one of the big ones we see with our breast cancer patients. Acute toxicity is the one that we recognize early on in the therapy. It is very transient. It tends to resolve on its own. You stop the medication, it goes away. Chronic is the one we worry about. Those are the ones which can either be recognized within 1 year or detected longer. As Dr. Ninnery had mentioned, depends upon the dose. Cumulative dose is important, which means how much dose are you getting over time? And it can manifest in the form of function decrease in the heart muscle. So how do I know I could be at risk, or somebody I love who's getting this therapy could be at risk? One, if they're getting higher doses. Two, if they have underlying risk factors, if they've had a family history of weak heart muscle, if they've had lipid abnormality themselves, if they're older, if their functional capacity is lower, that patient population is more predisposed. But the one important factor is the dose, and dose. We know that cumulative dose is really important. So when we see a patient is high risk, we want to go with the lowest possible dose, and we monitor them very, very closely, because the first sign may be weakening of that wall or that heart muscle. And then we stop the medicine, and the heart muscle typically acutely will come back. If it's been for a long time, it may not come back. There is a lot of difference from patient to patient, but there are factors that can increase the likelihood, particularly what are you getting in addition to that chemotherapy? It could be something over the counter. It could be something that you're taking for completely different medical condition, or it could be a part of the chemotherapeutic regimen itself. This is just to give an idea of how we follow the guidelines. There is specific recommendations. There are numbers that are followed. There is no guesswork involved. There's timelines that we follow. And now, one of the modalities one of the questions that comes up to us as a cardiologist is, how do you want to look at the ejection fraction in this patient? And there is an issue when we talk about echocardiogram. This is an image. This is what an echo looks like. So this is the left ventricle. This is the chamber of the heart that pumps into the body. This is the atrium. This is the right side of the body. And what we have to do is, I'm looking at this echo and I have to say, what is the ability? How is this contracting? You see all the walls are coming in. This is what a normal heart function looks like. And the normal quantity of heart function typically is reported as being 55 to 60%. This is another view of the heart. Now, somebody will call it 50%, another physician might call it 60%, somebody might call it 65%. What I'm trying to show you here is that there is no number associated with it, and how an echocardiogram can just be an estimate. So the test that, and we know that if we actually do a good job with understanding the heart function, we are able to decrease heart failure by almost 7 times. So it's really important to get it the right way. And the test we recommend now is a MUGA scan, if you want to truly get the right number when it comes to ejection fraction. The other new test that's available, which can be incorporated in the echocardiogram, is strain imaging, which tells us about, at the cellular level, each brick of the wall, what is the stress that each brick is facing. It's called the longitudinal strain imaging. Gives us very early idea, early identification of patients who will have heart failure. Then one question we get asked, can I just do a blood test? And that's a great question. There's also blood tests that help us direct in one way or the other. There are studies that are underway, but these are the tests you'll hear about: TROP-T, MYO, BNP, proBNP. If those are increased, there may be some association with higher risk in patients. We just watch them closely. And then there's high sensitivity troponin. If that's high as well, it tells us about the strain on the heart, and we watch those patients very closely. The treatment we do, as Dr. Ninnery had mentioned, we have ACE inhibitors, lisinopril, losartan. The beta blockers that are given to the patients should not also be the same. It's patients who have heart attack. When I'm a plumber, I'm opening up a clogged artery, it's metoprolol, low pressure. But when it is cardiotoxicity from chemotherapy, it's carvedilol or nebivolol that are different, because they work on different receptors in the heart. So even if you're getting the same drug class, all the medications in that class are not built the same for our patients for different diagnoses. Every heart failure is treated differently. Every weak heart muscle is treated differently. Herceptin also, Dr. Nuri did a great job. I'm just going to focus on the heart failure that happens with it is typically reversible. Once we stop the medication, it comes back. We treat the patients with lisinopril, losartan, beta blockers, follow their MAGA scan. If their MAGA scan looks better, we have had patients who needed it again and we resumed it with underlying therapy with these medicines and they did well. So it is case to case basis and the risk of the patient. Again, there are algorithms that we follow for this. One thing I also want to touch upon is radiation therapy. And as a cardiologist, radiation therapy is not benign. And it has risks. One of the questions in the chat was about what's down 10 years, right? 10 years from now. This is one of those things, radiation, that causes an issue 10 years down the road. And the issue may be in one of the doors, tightening of the doors, which we call aortic stenosis, is one of the, where we have valves that are needed over time. And the second issue that I see as a plumber is blockage in the arteries of the heart. And these blockages occur right where the artery takes off, which can happen in the left main and RCA. So we're talking about tight blockages that happen not because of cholesterol deposition, but because of change in the collagen from the radiation therapy that the patients have gotten. And it is more common with left-sided breast irradiation. So more focused therapy is better. And when you have risk factors. So anybody who has had radiation therapy, I would urge you to make sure you get EKGs and you get tested from time to time and make sure you know your lipid numbers. Make sure you understand that the risk is much higher in the next 5 to 10 years. This is something I wanted to show as well because it comes up all the time about the functionality of the artery. So it's not just the blockage, but the functionality. For example, 5-fluorouracil is one of the agents that can cause vasospasm. And what is vasospasm? This is a coronary angiogram where you can see this is the front artery of the heart. And this is where the artery takes off, and this is the front artery that supplies 60% of the heart muscle. It's called the widowmaker in the world of cardiology if you develop a blockage. And in this patient, we gave a medication to see the reactivity because this patient needed 5-fluorouracil, which can cause vasospasm, but she was having chest pain, going to the jaw, going to the arm. They wanted to see, hey, does she have vasospasm? Can we give it to her? Acetylcholine that was given to this patient typically should increase blood flow in the artery. But in her case, it completely shut down the artery. You can see there's no blood flow coming down right there. Compared to here, where we can see this artery is wide open. This is what it should look like. So this is how we understand that this patient has vasospasm. The other test that we can do is to check for microvasculature, which is 80% of the blood flow. And that is also done. These are numbers that we look at. We look at the resistance that helps us understand the health of the arteries, not only the big ones, but the smaller ones, which can increase the risk of stroke and heart attack in our patients. I want to make sure we have time for discussion. I'd like to just wrap up with the fact that it's very individual, treatment that we give to our patients. It depends upon your risk profile. And again, the treatment may not be the same that you get compared to what another colleague who has had breast cancer will get, because your underlying risk factors are important. There's one test that I would recommend, everybody know their numbers about, and that is a lipid panel, which is prevention lipid panel associated with ESR, CRP, and lipoprotein little a. The triad, the three of them in particularly perimenopausal women, predicts the risk of stroke and heart attack at baseline, something that's not a part of our routine stratification for women. We follow the Framingham risk score, which we got of men. So women risk factors are usually not taken into consideration when we assess their baseline heart risk. And those tests are something that I recommend to most of my patients.
Okay, so we had a request to write those panels out, and so yes, we will ask Dr. Serene to do that. And after Banter, we do send a written summary out after, so we can email that out to everybody who signed up. Because even though it's recorded, that would have been like
that would have been amazing to put it. Yeah. Okay, let me ask. We've got a couple questions, Dr. Serene. That was both of you. That was fantastic information. Thank you. I've learned so much. One question that we'll start with, and we are going to keep a close eye on time here. We're running short, but is the cardiologist, I mean, I understand you would be biased towards the specialist. I certainly understand that, but can we follow up on lipids and this kind of stuff with our primary care physician, or do you recommend that as a breast cancer survivor, we enlist a cardiologist for that kind of monitoring?
That's a great question. And just like our patients are built differently, our primary care physicians are built differently as well. And there are some who are very comfortable with lipid management, some are not. I know some phenomenal PCP, and I would ask them right away, hey, and you will know, are they managing your lipid panel? Are they asking the right questions? And there are PCPs out there who can do a brilliant job at it. So you don't need a cardiologist, but if your LDL level has been consistently high or it's not addressed during your primary care visit, then I think you may benefit from getting more specialists involved, especially as a breast cancer survivor.
Yeah, that's fair.
Okay. One more quick one before we go to the chat. So why is it that it's standard of care to get an echocardiogram or a MUGA before you do chemo, but not after? Like, is it not appropriate? Like, would it take too long, or does it take longer to see the damage? Or to me, it seems like a little bit of a disconnect, but I'm not a doctor, so I was wondering that while you were talking.
That's actually that's a great question. And that's also true for when we start statin lipid therapy that we do. So every test we do in cardiology or in medicine overall, it has a lot of factors that determine it. We want to do the test to get the information we need without getting unnecessary information that triggers more unnecessary testing.
Okay.
Sense. So when we get a baseline echo or we get a baseline MAGA scan and we know the heart function is good, then
Right.
the chemotherapy with minimum dose, because we know which dose can cause a problem. And if
Right.
they're feeling fine, then there is absolutely no clinical need to reevaluate the EF.
We're
It
not going to worry
depends
about
upon how you're feeling.
it. As long as I'm good, no worries.
But if you have risk factors at baseline, then it's not inappropriate to check it again.
Mhm.
Oh, okay. That makes sense.
Yeah.
Okay.
All right. This came in from the chat. Does damage to the heart from radiation on the right side affect the left side as well? Is there sort of a spread of radiation effect when radiation isn't in the direct field?
That's also a great question. So left-sided, the likelihood is higher, but yes, it can also happen with right-sided radiation. The one thing, if you do not have any symptoms and if you're postmenopausal, if you don't have any symptoms, it's not a bad idea to ask for CT angiogram of the coronaries of the heart, which I'm going to type down.
We like everything in
What this is a test that looks at the arteries in the heart. And as I was mentioning about the origin from the aorta, this test looks at it. A stress test is not a good test because that will miss it.
Mm-hmm.
There's something called balanced ischemia that happens with stress tests, but this is the test that's great to look for damage to the arteries in the heart from radiation. And of course, an echocardiogram or a cardiac MRI can typically tell us about damage to the valves.
What about a calcium test? Is it of
Well,
any?
that's a great question too. So CT angiogram of the coronaries is a little bit more sophisticated than the calcium score because the process is not calcium based. It is because of the collagen making a fibrotic cap around the artery that causes the blockage. So calcium test may be okay, and the problem may still be there.
Oh, okay.
That's
All
great.
right.
I was going to add one thing too about the radiation piece. Thankfully, the technology for radiation in our machines has come a really long way. So the cardiac effects are way less than what we used to see back when we did mantle field radiation for these lymphomas and things, and it would just wreck people's hearts. Actually, one of my first publications was looking at a cohort of survivors from St. Jude and the insane rates of coronary artery disease that these young survivors were getting. Thankfully, we've really come a long way with our radiation technology since then. We're really good now at being more precise with the radiation and minimizing the effects off target to the heart, so we see much lower rates. Our radiation oncologists, when they do mapping, they will often plan to make sure that they are minimizing effects on the heart, especially for the left side. I don't know if any patients have gone through it. They make you hold your breath and try to time it to make sure. And if they have concern based on their planning that they're getting too close, we will often refer to the Proton Center for proton beam radiation therapy. When that first came about, it was really hard to get insurance coverage coverage for that, and the cost is just insane. Now I think we've made some advances with lots more data and are able to get insurance coverage. And we at Tennessee Oncology, we're usually able to find ways to get it covered for patients with left-sided breast cancer. So always something worth asking your radiation oncologist about if they feel like proton beam radiation therapy would be more appropriate for a patient. So always don't ever be afraid to ask and bring that up in a conversation if they don't.
That's wonderful.
So helpful. This has been very, very
All right.
informative.
Do we have time for one more? Because there's one more question I really wanted to ask Dr. Serene about. I had seen in one of the YouTube, so I was stalking you, that you had talked about heart disease. It's the #1 cause of death of women in the United States, more than all cancers combined. Not saying that breast cancer isn't a big deal, but it's a big deal. And you had mentioned that women have additional risk factors, right? I think one of them was pregnancy. I was hoping that maybe you could talk about that a little bit.
Thank you. Yeah, no, breast cancer is definitely a big deal, and nobody should suffer from any diagnosis at all. What's
Right.
striking about heart disease is that it has been marketed as a heart disease, that as a disease of the men.
Right.
Just don't consider women are likely, and things as simple as having 3 or more children. Just having 3 or more children puts you at higher risk of heart disease, almost by 20%.
Wow.
Women, I mean, when have you gone to a primary care physician or cardiologist and they have asked us, what was your age of menarche? Did you have your menopause? Do you have your uterus? Are you perimenopausal? Because if you have your menopause in your 40s or you lose your ovaries in the 40s, your risk of heart disease, having a heart attack, stroke, goes up by almost 30%, which is significant. But we miss on those because we just don't talk about things like that.
Yeah.
One of the other things that, and this is one of the things we're trying to do here at AST, is to see if we can look at mammograms and look at breast artery calcification on mammograms. We all get routine mammograms, and there is breast artery that is seen by the radiologist. If there is calcium, any degree in that breast artery, it predicts stroke and heart attack risk. And we should be able to report that and tell women who are at higher risk of heart disease about it. So you're right. We don't do a good job screening women for specific risk factors that affect them, female predominant risk factors, and we have to improve there.
Yeah.
Well, I feel like we could do a whole nother hour on just that, and probably should at some point. So maybe we need to continue this conversation, but in the interest of time, we'll say thank you for today. I did just want to reiterate, we had some question about if you want to listen to this again or you want to share it with somebody who might find this information helpful. Give our production team a few days, but usually this is up on our website. It's bragroups.org. bragroups.org, and you can find this recording as well as others on different topics. Yeah,
Also
somebody's
YouTube.
saying
It'll be on
Mm-hmm.
maybe
YouTube.
an hour and a half next time,
Yes,
so we can have more time to
90
chat
minutes
because
next
there's a
time.
whole lot of information to delve into, and it really is too much to just try to make it a bullet point, right? It's
Right.
kind of difficult, but and I also forgot to say, just because I don't want to failed to mention this, under the education umbrella of BRA, we also have a nutrition component that involves a registered dietitian who helps us with all kinds of healthy habits when it comes to how we're fueling our bodies after cancer. So I did want to mention that because diet and exercise are obviously such a key part of cardiac health in general, whether you've experienced breast cancer or not. And so that's just something that we all can be trying to live healthy lifestyles in that way. So if that's helpful to you, please know that we're here for you. But Dr. Nunnery and Dr. Serene and Dina, thank you so much for your participation today and for joining us. We are so appreciative, and I learned a ton. Thank
Yes,
you.
you were wonderful.
Thank you.
Thanks for having us.
Thank you for having us.
It's a lot of fun. Y'all have a good afternoon.
All right. Thank
Thanks,
you.
everyone. Take care.